Welcome to this video. We're going to be talking about pharmacological management in patients with chronic heart failure. Before we get into the full content of the video, I want to introduce you to our two cases, Mrs. Tetley and Mr. Scott. So first of all, we have Mrs. Tetley. She's an 82-year-old female with hypertension, COPD, arthritis, and mild renal impairment. She has heart failure with preserved ejection fraction, and as you can see here, her heart is thickened from long-standing hypertension. She also has mild diffuse coronary artery disease, but no history of an MI. She was admitted to hospital with pneumonia and worsening symptoms of heart failure, consisting of shortness of breath, orthopnea, and PND. So while she was in hospital, she was treated for pneumonia and also heart failure and diuresed for 15 pounds. She was discharged home in 7 days with a request for a follow-up appointment. Our next case is Mr. Scott. He is a 76-year-old gentleman with a history of heart failure with reduced ejection fraction secondary to coronary artery disease. So as you can see, he has a large weakened heart, or what you can also call an ischemic cardiomyopathy, as he had an MI and coronary artery bypass surgery 10 years ago. He requires medical management since he has no new blockages identified on a recent cath. He has a history of chronic renal insufficiency, dyslipidemia, and he quit smoking 10 years ago at the time of his MI. So what can we do for Mrs. Tetley and Mr. Scott? When you think of the management of heart failure, it really is a multi-pronged approach. For the purposes of this video, we will focus on medications for chronic heart failure. So the specific objectives of this presentation or this video are outlined in the slide, and specifically we will provide an overview of the pharmacological optimization in people with chronic heart failure as based on the recent Canadian Cardiovascular Society heart failure guidelines. But also embedded in this video are some practical tips for titrating and optimizing the medications using these case studies. So heart failure, when we think of the pharmacological management of heart failure, we also have to think about ejection fraction. So to recall, an ejection fraction is the percent of blood that you pump out with each beat. The normal ejection fraction should be at least 55% or higher. In someone with heart failure with reduced ejection fraction, that is when their ejection fraction is 40% or less. Someone with heart failure and preserved ejection fraction is someone who has heart failure and their ejection fraction is 50% or more. The reason we point this out is actually the pharmacological management of chronic heart failure will be different depending on if they have heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. First, we will start with our case of Mrs. Tetley. To recall, she has heart failure with preserved ejection fraction. The guidelines for HFpEF are fairly limited. Unlike the many studies that inform medication management in people with heart failure and reduced ejection fraction, there is very limited evidence to guide management of HFpEF. Studies completed to date have not shown any mortality benefit, but there are 2 studies that have shown reduction in heart failure hospitalization, and they are reflected in the CCS recommendations on this slide. Candesartan and ARB can be used to manage hypertension and contribute to these positive outcomes. There are also patients with HFpEF that benefit from spironolactone. I find the patients who have a lot of right-sided heart failure with liver congestion tend to respond well to this MRA. But really, the bulk of the management of HFpEF is to control blood pressure, control the heart rate, especially if they're in atrial fibrillation. Controlling underlying risk factors that can contribute to HFpEF, such as diabetes or coronary artery disease, is also important. Finally, you need to be cautious with the use of diuretics in patients with HFpEF. I find these patients have a fine balance between heart failure symptoms and renal impairment. It doesn't take much to put them into renal failure when you're trying to chase that last little bit of fluid with the diuretics. You may find that they have a little bit of extra fluid on board, but they feel okay with usual activity and the kidney function is reasonable. In this case, that last little bit of fluid is not a problem, and there's no need to increase the diuretic therapy at that time. In heart failure with reduced ejection fraction, as you can see on this, we talk a lot about triple therapy. And triple therapy really targets the sympathetic nervous system and the renin-angiotensin-aldosterone system that are activated in heart failure. So on this slide, you will see that when the cardiac output is reduced in the setting of heart failure with reduced ejection fraction, you get activation of the sympathetic nervous system and the renin-angiotensin-aldosterone system. And as a result, you get an increase in heart rate and vasoconstriction. You actually start saving water where your kidneys filter a little bit differently, so that's where the fluid accumulation comes from. And over time, your heart actually gets bigger and weaker. So if you leave well enough alone, the body's reaction to inadequate cardiac output will actually make things worse over time. So what we try and do is look at blocking the renin-angiotensin-aldosterone system, or I'm going to say the RAS, and the sympathetic nervous system. So you can actually help prevent or reverse the negative effects that they impose that actually make heart failure worse. So in return, you have less vasoconstriction, less fluid retention, and improvement in cardiac function over time. I just want to point out that diuretics do help improve symptoms of heart failure, but really all they're doing is kind of cleaning up the mess or cleaning up the fluid overload. They do absolutely nothing to alter the disease process of heart failure. So ideally, we want to optimize medications that turn off the RAS and the sympathetic nervous system, so hopefully you avoid fluid buildup in the first place, and in doing so, you have less need for the diuretic therapy. So on this slide, it's a closer look at the renin-angiotensin-aldosterone system, or the RAS, although simplified, so we can see where the sites of action are for pharmacological therapy. So first of all, you can see ACE inhibitors help block the conversion of angiotensin 1 to angiotensin 2. And angiotensin 2 does a lot of nasty things, so we want to decrease the amount of angiotensin 2 circulating. Unfortunately, you can get an increase in the bradykinin, which leads to the cough with an ACE inhibitor. So some patients do not tolerate this medication. So angiotensin receptor blockers are the alternative when people can't take ACE inhibitors because of that nasty cough. Few, but there are patients that do experience angioedema with ACE inhibitors, and they also cannot take those, and an ARB can be considered in that situation. On this slide, you will see a list of the medications that have been recommended by the guidelines that can be used in heart failure with reduced ejection fraction that target the renin-angiotensin system. As you can see, there's a full list here. It really doesn't matter which one you choose, whether they want once a day, twice a day, what's cheaper, what's more reasonable, what do they prefer. It really doesn't matter. I think the key is to start at a low dose. As you will see, there's some starting doses there, and titrate to their maximum target, or to the target dose, or to the maximum tolerated dose if you can't reach the target dose as recommended. On the next slide, you will see that there are a couple practical tips at titrating medications. And I must admit, it is a little bit of an art and a science, because you are doing some finessing to really try and make it work for that patient, because ideally you'd like to get to target dose where they get the best benefit. So you do need a serum baseline creatinine and potassium, because these cannot be started in people with severe renal impairment or hyperkalemia. Once you start medications or titrate medications, you will see that you will need to follow up on these values. When we see a 30% deterioration then in their renal function, then you do need to back off. One thing is, we're not using ACE inhibitors or an ARB for management of hypertension. We're using them to help block the renin-angiotensin-aldosterone system. So if people have asymptomatic low blood pressure, that is absolutely fine. You may want to consider a once-a-day dose to be taken in the evening if they do have underlying hypotension. The other thing you may consider is decreasing the diuretics, because hopefully with the introduction of the ACE inhibitor or the ARB, you actually have less fluid retention, so the low blood pressure might be from volume depletion, and so look at backing off on the diuretic therapy. The other area that we use to help block the renin-angiotensin-aldosterone system is using an aldosterone antagonist, and that is also part of triple therapy. There are two aldosterone antagonists, or mineral corticoid receptor antagonists, also known as MRAs. You can see here there are two. It doesn't really matter which one you choose. Either one is just fine. What I do find though is some patients with spironolactone will get gynecomastia, which is very uncomfortable for men. About 10% will get that. So then consider a eplerenone. It doesn't have that side effect. Otherwise, they're very similar. If you're a little concerned about some underlying hyperkalemia or renal impairment, start at a little dose, like 12.5 milligrams Monday, Wednesday, Friday, or 25 milligrams alternate days, and then slowly titrate up as tolerated. There are a subset of patients that cannot tolerate an ACE inhibitor or an ARB because of underlying renal impairment or ongoing hyperkalemia. In that case, we use the hydralazine nitrate combination. And as you can see here, we also start with a small dose and titrate. The group that really get the best benefit from the hydralazine nitrate combination is people of the African descent, and that is from a study that was done back in 2004 that showed significant improvement in outcomes for this population. So you can see the guidelines recommend this combination in the African population, even in the setting of ACE inhibitors and ARBs. So the other part of triple therapy is blocking the sympathetic nervous system, and we use that with beta blockers. There are two main beta blockers that we use in patients with heart failure and reduced ejection fraction, and they're bisoprolol and carvedilol. Both medications work very well, but there are some subtle differences between the two that will help you figure out which one may be best for your patient. Bisoprolol is very base selective, so it doesn't have the effect on the blood pressure that carvedilol may have. Carvedilol blocks the beta 1, beta 2, and alpha receptors, so you will see a hypotension in people with underlying low blood pressure. However, in patients that have stubborn high blood pressure, carvedilol may be very helpful. We find bisoprolol is once a day, and so people that have that problem with the fatigue, ongoing fatigue, we tend to use bisoprolol and they can take it in the evening. There are some other tips on the slide there to try to manage the introduction and titration of beta blocker therapy in the setting of hypotension. One thing to keep in mind, if patients do have a little bit of extra fluid on board, that's not the time to be titrating beta blockers. They need to be euvolemic, because sometimes when you first increase that beta blocker, they do get a little bit of fluid retention. We usually chase it away with a little bit of Lasix, but we try and keep it on board as much as possible because we know in the longer term they will feel much better and do much better for that. So far we've mentioned triple therapy with your ACE inhibitor or ARB, your MRA, and your beta blocker. And these are really trying to target the bad things that go on through the renin-angiotensin-aldosterone system and the sympathetic nervous system. But when there is a low cardiac output in the setting of heart failure with reduced ejection fraction, there actually is another system that is triggered that actually does a lot of great things for your body and helps improve the disease process and symptoms of heart failure. So you see on this slide that we've highlighted that when there is heart failure, reduced ejection fraction, and low cardiac output, there actually are some good things, and that is really the release of natriuretic peptides. And these natriuretic peptides lead to decrease the sympathetic tone. They also help with a natural diuresis, and so in effect they actually help improve your symptoms of heart failure. So you can see actually that if we got more circulating natriuretic peptides, that will help in heart failure. They tried a study with a medication that sort of mimicked those natriuretic peptides, and that study didn't go so well. It didn't really make a big difference. So what we've done now is look at research that actually blocks the breakdown of the natriuretic peptides, so you actually keep more circulating natriuretic peptides in your system. A closer look, you will see that neprilysin actually is responsible for the breakdown of natriuretic peptides. So if you block neprilysin, then you will have more circulating natriuretic peptides. So the medication that has been used is a neprilysin inhibitor, and we've also known that as sacubitril. So in this slide you will see that the target is the neprilysin inhibitor. So by blocking the neprilysin inhibitor, you actually have increasing of circulating natriuretic peptides. But unfortunately, as the natriuretic peptides remain elevated, neprilysin also helps break down angiotensin II. And to recall, angiotensin II is part of the RAS and makes heart failure worse. So we need to complement the fact that you've got some medication that is a neprilysin inhibitor, but you need to put another medication with that to block the effects of the angiotensin II. Initially, they tried an ACE inhibitor, and that didn't work so good because it really increased the risk of angioedema. So we now have a medication that has a neprilysin inhibitor, which is known as sacubitril, and also with that is an ARB, which is valsartan. So sacubitril valsartan is the medication that is used to help manage heart failure, and it would replace an ACE inhibitor or an ARB. So you can see here that it comes in small, medium, and full strength. Often we start at the small dose for titration, but you do need to be mindful that you need some time, about 36 hours, for if they were on an ACE inhibitor, to wash out that ACE inhibitor effect, because you don't want the problem of the angioedema. Even though it's a small risk, it is a risk. So you need a washout with the ACE inhibitor. You don't need a washout if they were previously on an ARB. The following slide here shows that Entresto, or sacubitril valsartan, or also called an ARNI, is available in Ontario through the limited use, and the information is here on the slide that you can see of the number used for limited use. So another medication that has been offered in addition to triple therapy is a heart rate lowering medication. So we know that a fast heart rate is associated with negative outcomes. And so there's another medication that's available called ivabradine. And this medication basically slows the heart rate. It acts on the sinus node, and that's all it does. So unlike a beta blocker, it doesn't cause hypotension. It doesn't have a rebound effect if it's stopped abruptly. So ivabradine can be used to slow the heart rate when someone is in sinus rhythm, when their ongoing heart rate is consistently above 77, despite using a beta blocker. Some patients may have full strength of a beta blocker and still need ivabradine because their heart rate is fast. Other patients may not be able to take beta blocker because they have underlying reversible airway disease, or some people may have a little bit of a beta blocker, but they just can't tolerate the full titration because of symptomatic hypotension. In all of these cases, ivabradine would be available for use or appropriate for use. There are some things to be mindful that it does need to be taken with food. So just keep in mind, there are a couple practical tips with ivabradine that you can see on this slide. It should be taken with food. It is twice a day. It should not be taken with grapefruit juice because it doubles the exposure of the Lancor in the system. In the older population, it's certainly fine to use ivabradine. Just be mindful that they are more susceptible to adverse events, so you might want to start a little bit slower and in the titration with a smaller dose. Ivabradine has been approved in Ontario through limited use. The information is here on the different doses and also the limited use conditions and the limited use code. Thank you. So at this point in time, we're going to go to our case studies with Mrs. Tetley and Mr. Scott and try and apply some of this knowledge to managing their heart failure and their fluid balance. So for our first case study, we're going to start with Mrs. Tetley. So to recall, Mrs. Tetley is an 82-year-old woman. She has heart failure with preserved ejection fraction and a number of comorbidities. She was discharged home and she was to be seen in 7 days. Unfortunately, she couldn't get a ride, so you're seeing her now 2 weeks after her hospital discharge. She tells you she's short of breath walking to the mailbox. She denies any symptoms of orthopnea, PND, or edema. Her weight is stable. Her blood pressure, which she has checked at home for many years, she brings in her log, and her blood pressure at home is consistently greater than 150 millimeters of mercury, and her diastolic blood pressure is averaging around 80. Her blood pressure on exam is 166/78. Her pulse is 75. Heart sounds she has a soft S4 gallop. Her lungs are clear. Her JVP is normal, and she has no peripheral edema. Her lab work is reasonable with a creatinine of 124 and a potassium of 3.8. You can see her by her medications. She takes a little bit of Lasix, some Lipitor, some Norvasc. She's got some puffers. Her irbesartan is 300 milligrams daily, some calcium and vitamin D supplement, and she applies a Nitrodur patch in the morning. So basically on her assessment, Mrs. Tetley has NYHA class 3 symptoms. She's euvolemic. So what do? Do we leave well enough alone? What we found though is that when you look at her risk factor control, her blood pressure could use some little tightening up and perhaps some optimization of her medications. So as far as her risk factors are concerned in her hypertension, interesting enough that we do need a little bit of improvement in her blood pressure, but she tells us she's been a poor sleeper. She's got some underlying issues with sleep for years. Her blood pressure is a little stubborn, so we're actually going to explore the idea of sleep apnea with her. One thing to caution, thiazides are commonly used in the management of hypertension. However, they will potentiate the effect of Lasix and create a high-risk situation for kidney injury or electrolyte imbalances. So if you want to consider a thiazide, you really have to be careful with the monitoring of her renal function because in the setting of when they're also taking Lasix. As far as her medication optimization, we'd probably consider adding spironolactone. She does have some mild renal impairment, and given her age, we'd probably start with a small dose, like 12.5 milligrams daily, and reassess her blood work in 7 to 10 days. Ideally, if we can titrate to 25 milligrams daily is tolerated. The last thing is there really is no evidence that will improve outcomes for Mrs. Tetley for using the NitroDur patch. She doesn't have flow-limiting coronary artery disease. She doesn't have angina, so it's probably something you can get rid of. Patients are always happy to get rid of a medication whenever possible. Flipping over to Mr. Scott, to recall, he has heart failure with reduced ejection fraction, long-standing coronary artery disease. He hasn't been hospitalized for a while, but he's coming to see you for follow-up. In the meantime, he was on a 4-day bus trip to a casino. He noticed his ankles were starting to swell, but he figured it'd sort itself out when he got home. He had been doing a lot of sitting. And after a couple days at home, though, he woke up in the middle of the night, gasping for air, and he went to the emergency department. While he was there, he received IV Lasix. They increased his diuretic dose to 120 milligrams PO daily, and he was to be followed up with his family physician in 1 week. Unfortunately, he had trouble getting a ride and was hoping things would settle down anyway, so he came to see a follow-up visit in 2 weeks' time. Now after 2 weeks, he's very tired, he's lightheaded when he's standing up, he is short of breath when walking up a few stairs. He denies any orthopnea or PND, but he has lost 7 pounds in the last 10 days. On exam, he's 165 pounds. You will see here his blood pressure is 104/60 sitting and 92/50 standing. His pulse is regular at 72. He has a little bit of pitting edema. He's got a systolic murmur, which is not new. His JVP, are unable to visualize it. His creatinine is mildly elevated, 180, and his potassium is 5.3. You can see his current medications here. He's on an ACE inhibitor with perindopril, he's on a beta blocker, his aspirin, his Crestor, and his Lasix at 120 milligrams PO daily. So assessment findings, when we look at him, he's NYHA class 3. However, we find that he is volume depleted. And patients with heart failure, you really have 3 choices with their volume status. They're either fluid overload, called wet, they're either volume depleted, which is dry, or they're just right euvolemic. So in this situation, he is volume depleted. What do we do next for Mr. Scott? So on this slide, we've got a couple of options. So we can either increase his fluid and sodium intake, we can look at decreasing the Lasix, maybe we should decrease the ACE inhibitor, maybe we should decrease the beta blocker, or maybe we should change the beta blocker because we know that carvedilol is not beta-1 selective. He does have hypotension, so perhaps we should switch him to bisoprolol. So Mr. Scott voted for A, just to give you an idea, but that's not such a good idea. So when you think of the rationale for some of these decisions, on this slide you will see that the volume depletion, although we want to increase fluid and sodium intake, even though Mr. Scott thought that was a great idea, you can see it's not a great idea because we really don't know how he's going to respond to that little bolus. So ideally we're going to consider holding the Lasix for 24 hours and start at a dose of 80 milligrams BID. And Mr. Scott loved the idea of not having to take a diuretic for the day. We really don't want to decrease the ACE inhibitor or the beta blocker because they are disease-modifying medications, and they're really not contributing to the hypotension at this point in time. Ideally, it would be nice to change the beta blocker, but maybe at another visit, you don't want to do too many things all at once. 2 weeks later, Mr. Scott says he is still tired, but his symptoms are improving. He is short of breath climbing one flight of stairs, which is typical. No orthopnea, no PND. You can see here he's gained a couple of pounds. There's no longer a postural drop in his blood pressure. His pulse is regular at 72. There's no edema, his lungs are clear. He's still got the murmur, which is unchanged. His JVP is normal at 3 centimeters above the sternal angle. His creatinine has improved slightly and his potassium is stable. So other than changing the Lasix at the last time, that's pretty well it. But he is NYHA class 3, he is improving, and he is more euvolemic. Some people might think, well, if it's not broken, don't fix it. But really, this is where we need to get into some of the fine-tuning of his medications. He's still got some underlying fatigue. And even though there may be a number of things you might want to look at that's contributing to the fatigue, let's first look at, are there any simple medication changes that we can consider to help address the fatigue. So you may consider switching the carvedilol to bisoprolol, and then often we ask them to take bisoprolol in the evening. Probably start with 5 milligrams just to see how he reacts to this dose, given he is older, and we really don't know what there is an equivalent from carvedilol to bisoprolol. We also need to keep in mind some of that self-management teaching, is that if he does notice some fluid accumulation, to contact the clinic or contact yourself before he gets to 10 pounds or 7 pounds. So perhaps he can call sooner so we can do something before it deteriorates. Now we're looking at his follow-up visit. He has now come to see you after the titration or the change of the bisoprolol. He is feeling better. And he has tolerated that change quite. What do we do now? He is less fatigued. He is short of breath still with climbing one flight of stairs. He's walking 15 minutes. You can see his weight's here at 170 pounds. His blood pressure is still reasonable. His pulse is 76, and renal function appears stable. So he's NYHA class 3. He's tolerated the change in the bisoprolol. What is the plan for Mr. Scott now? You can consider no changes. He's back to his usual state. You could look at, maybe we should increase the ACE inhibitor. He's not at his full strength. Maybe we could actually titrate the bisoprolol because he's not at target dose. But triple therapy, you kind of look at adding an MRA, and he's not on an MRA. Maybe we should do that. Or I've heard about those new drugs. I wonder if it's time to start any of those new drugs. Even though there's a couple of options, here are some rationale for the different choices. Obviously, A is not the right answer in the sense that he may appear back to his usual state, but there really is room to optimize his medications because we know that down the road it'll help prevent disease progression, help prevent that symptom progression, help prevent hospitalizations. So that's really important. So how can we accomplish that? You could look at increasing the perindopril. That would be reasonable. Just watch the creatinine and the potassium. You could consider increasing the bisoprolol. He's not at target. Probably would go to 7.5 milligrams QHS. You could look at adding the MRA as part of triple therapy. Probably a small dose, giving his renal function to start, either 25 milligrams alternate days or 12.5 milligrams daily. And one of those new drugs, the ARNI, which is the sacubitril/valsartan, it would replace the perindopril. I think it would be a future option if he's symptomatic, despite the optimization of the beta blocker and the MRA. As far as the ivabradine, it's too soon. If he's tolerating the beta blocker titration, certainly continue with that. And if he still has a fast heart rate that's consistently greater than 77, then I would consider adding the ivabradine to his medication regimen. You don't take away the bisoprolol, you just add it in. as if it were an ARNI, you would have to take away the Coversil, allowed for that, or the perindopril, allow for that washout, and then start the ARNI. When we think of heart failure with preserved ejection fraction, as far as the pharmacological management, it's really blood pressure control and heart rate slow, because that's all we know. How you do that, good medications. Be cautious though with the hydrochlorothiazide in the setting of Lasix if you choose to use thiazide. You could look at managing the risk factors, and definitely considering an MRA if they're symptomatic and you want to help prevent hospitalization. As far as heart failure with reduced ejection fraction, we've got to look at triple therapy that blocks the RAS system, the sympathetic nervous system. We do that with ACE inhibitor, ARBs, MRAs, and a beta blocker. If you find that they have ongoing symptoms, you can look at some of the newer medications, such as an ARNI, which would replace an ACE or an ARB. And you could look at ivabradine to add on to beta blocker therapy if their heart rate is consistently greater than 77. I always say thank you for your attention during the video, and hopefully this will provide you with some additional insight to support your patients with heart failure. Thank you.